to is how do we see them? What do they look like? If I come across this, what am I expecting? So when we start looking at the chapter 5 pathology, we know that we're in the shoulder girdle. What is a shoulder girdle? What do we define a shoulder girdle? Anyone?
The clavicle, scapula, shoulder, and the humerus.
Upper humerus. What is the purpose of a girdle? Because we have two of them. You've already been introduced to the shoulder girdle, and now you're going to be introduced eventually at the end of the semester with the pelvic girdle. What are we trying to imply here?
It provides support and like range of motion.
It does, but one of the biggest things that we want to make sure that we understand, how are we attaching an upper extremity and a lower extremity to the axial skeleton? We have to have points of attachment, okay? Everything has to be connected. So yes, we don't have bones that extend off of the axial skeleton to connect the upper the upper humerus and the rest of the upper extremity. So we're using a combination of these bones, the clavicle, the scapula, and the scapula's connection with the upper humerus is going to be what attaches the entire upper extremities to the axial skeleton. Make sense? So they're basically fasteners. The girdles are like a fastener. Okay? Good. And they do provide us range of motion, especially at the girdles where you're having the connections. You'll have more range of motion here and then as well as in your hips. Any questions before we get started? When we're thinking about AC joint separation, what kind of projections, John, do we have for an AC joint? What are the two essential projections for an AC joint?
AC bilateral with weights and without weights.
What's the point of the weights? What's the purpose?
To open up the acromioclavicular joint.
So we're going to apply gravitational pull by giving you some weights. And so I want to be able to see what is going to happen to the acromioclavicular joint without any stress and then with stress. And so what they're doing and why we do a bilateral is to see the degree of separation. We have the ability to compare and contrast both sides, both contralateral sides. Make sense? So we can see right here, Asias, thank you for adjusting your camera, which AC joint has more separation than the other?
The right side.
Okay. Asias, I'll take it next time. Who was that?
Me.
Tracy.
Tracy.
Okay, good. Tracy, so we do have more separation here on the right side than we do on the left side, indicating that these two ligaments, because ligaments combine what, Tracy? Ligaments connect what?
The joints together.
Yeah, somewhat.
And the bones?
Bones. Ligaments combine or connect bones together. Good. Perfect. At the joints is where you'll have an articulation of these bones. Perfect. Good. Everyone understand AC separation. Now, the Bankart lesion we've talked about a little bit, and we're saying, well, what radiograph will we really see this? And someone had said the Gracie method, and that's good. The Hill-Sachs defect is more likely going to be visualized in the Lawrence method. The Bankart lesion is basically a type of tear or a type of lesion. Lesion is an opening of whatever the bone, the tissue, as you can see right here. So on repetitive motions, you'll start to see that labyrinth. Here's the glenoid. We know that glenoid is flat and it kind of has an indentation so that our humerus can sit in. So right here, you start to have a lesion form or a tear, and you can see right here on the labyrinth that there is a Bankart lesion. And this looks like a Gracie. How does it look like a Gracie? What is the distinguishing characteristics of a Gracie, Jalisha?
The characteristics of a Gracie? Are you talking about the
Yeah,
X-ray?
how can you tell a Gracie from an external and internal AP shoulder.
Because it's focused just on like the glenoid cavity area?
It is focused on the glenoid cavity area, but there's something specific about the glenoid cavity. And let's take a look. I don't know if I'm going to be able to see. You see right here? You see the glenoid cavity right here? You see how the glenoid cavity is kind of open, and we see the humeral head sitting inside of it? You see that? You can kind of see the round oval surface of the glenoid cavity. In the Gracie method, we've actually superimposed those sections. We're not able to see inside of the cavity. We have now opened up, we have separated the humeral head from the glenoid cavity. So that's what the Gracie does for us. And with that Gracie, we're able to see where there may be a lesion or tear in that articulating capsule, the auricular surface of the glenoid cavity, which is basically cartilage that is going to allow or minimize the friction of bones rubbing together. Questions? No? Hill-Sachs defect. Now, the Hill-Sachs defect is basically a type of lesion as well, but it affects a different part. Before we were talking about right here at the glenoid cavity, and you can see here again, the glenoid cavity, this is not a Gracie. The glenoid cavity is not superimposed. We don't have one border of the glenoid cavity superimposing the other. Okay, so this kind of looks like a regular AP shoulder external rotation. So what we start to see is the Hill-Sachs defect is we start to see lesions right here. What section of this is the humerus? What is that called?
The anatomical.
The what?
Anatomical neck.
The anatomical neck. So we start to see that lesion around the anatomical neck or the upper femora. Not so much the glenoid cavity, but the upper femora. Femoral. Femora, not femora. I keep going back to the leg. We're not there yet. So to the upper femori, we're starting to see that. Okay? Let's see. 1 second. So this picture gives you a good indication of where everything is. Here's your glenoid. This is what a normal looks like. Glenoid cavity, coracoid, clavicle, chromium, humeral head. When we start to see that Hill-Sachs lesion, which is going to be here in the posterior aspect of the anatomical neck. Questions? No? Oh, okay, so y'all are going to just let me breeze through this. Yay. So rotator cuff is probably one of the more frequent ones that we see. So rotator cuff is basically where you start to tear the types of either the tendons, which is going to connect muscle to bone, the tendons around the shoulder, so where you're able to do the most range of motion. What type of movement does the shoulder have, Javier? What type of movement does the shoulder have? It's not hinge. It's not gliding.
No, it's ball and socket.
Very good. So when you have a full range of motion like that, and if you start to put stress onto those tendons, you can create a tear. Most times, if you limit your range of motion and you get some type of anti-swelling medication, it'll start to repair itself. However, if you further injure it, it will cause you severe pain. And some people will look to have surgery for it. So when we're looking at rotator cuffs, because we can't see tears in radiographs, can we, Jesslyn? What can we see in radiographs, though, if we were talking about a rotator cuff? What is outlined right here in this image? What does it look like? What is this right here, if I had to point to that? What would you label it? What is that?
The head?
The head. I'm sorry, this is my cursor right over here.
Oh, sorry. Glenoid cavity?
The glenoid cavity, and this is the humeral head, right? And so what they're doing right now is saying this is a normal position of the humeral head when it articulates with the glenoid cavity. So how you can identify a rotator cuff tear is when you start to see a dislocation or a subluxation of the humeral head. What does subluxation mean again, Asias? Subluxation.
Partial dislocation.
Okay, everybody's getting Asias answers. So next time I'm going to call your name. Okay? All right. So Here we go. So it is a partial dislocation. So let's take a look at this. This is where we start to see a rotator cuff. Because if you can compare to the one that we have over here, we have the glenoid cavity. We kind of have a downward angle trajectory of that humeral head. Here, we have almost a perpendicular or higher articulation of that humeral head and how it's articulating with the acromion. You see how it's articulating with the acromion? Here's the coracoid. Here's the acromion. Here's the acromion. Here's the humeral head, right? So we're shifting that shoulder, that the positioning of the humerus. Make sense? So a rotator cuff is not going to show us a break. It's not even going to show us a tear. It's going to show us a dislocation or a subluxation, rather, of the humeral position. Make sense? Good. Bursitis, we talked about before. What does bursitis mean, Jolie? And only Jolie.
I'm sorry, I don't remember.
Okay. All right, John, help her out.
It's an inflammation of the bursa. They're like fluid-filled sacs that are in your joint.
Absolutely. They're fluid-filled sacs in the joint. They provide cushion and they provide movement. Now, remember, anytime you're moving your bones, you are adding friction. You are adding heat. This is where sweat and calories start to burn. So the more that you're moving, the more that you're creating friction on the inside. So this is allowing us to move. But what happens when there is repetitive movements of the bone? We start to feel the effects of that repetitive overusage of those muscles. And so what happens is we start to have that bursa fill or swell. So what happens, and this is a common effect that we'll see in the sonographers, maybe a bursitis of the shoulder, because you'll always hear that they're like, oh, my shoulder, because they're having that repetitive. But you can also see that with a lot of people who are doing a lot of mouse clicking. They'll say it's carpal tunnel, right? So a lot of the manipulation or fine manipulations of the hand. So you could go to therapy for that. But to relieve the pressure, we'll see right here, we'll do a draining of that excess bursa fluid through transducer, right? So sometimes they'll do some draining through ultrasound, and sometimes they'll just do it under fluoroscopy. How many of you have you seen a fluoroscopic examination where they're injecting either contrast into the person or withdrawing fluid? Good. They do happen. Good job. So make sure you're paying attention to that. Okay. So bursitis, we talked about it in the elbow. I gave you a demonstration of the elbow, but here we're talking about the shoulder. Bursitis is inflammation of the bursa. Got it? Questions? Shoulder dislocation is in your book. However, we've talked about dislocation, but I did want to cover this real quick. Now, what am I looking at over here? What kind of projection is this? Let me go ahead and go, Luke. What projection is this?
Scapular Y.
Okay, and what's the good. What's the purpose of the scapular Y? What are we doing a scapular Y for?
To get a better view, like of the whole scapula.
Well, not really, because here we've got the scapular body superimposed over the humerus. So it is a dislocation. It is a shoulder joint view. It is specifically to see, thank you, Luke, see the position of the humeral head. The humeral head on a scapular Y is going to lie right here at the base of the Y. So when you look at the Y, which is made up of the acromion, stem, here we got the coracoid, and then we have a superimposed body. Makes it look sharp, right? We have a lateral border superimposed over the medial border. And then what do we have? We have that arm sitting right down to the side, superimposing the shaft of the humerus superimposing the body of the scapula. So this is an orientation. Someone says, I think I dislocated my shoulder. I'm going to go back and I have to perform a Y. That's what the Y is for. Make sense? So let's take a look here. We have two types of dislocations. Okay, we have the anterior dislocation, which is more common, anterior dislocation, which is more common, and then you have the posterior dislocation. So again, here's my acromion, here's my coracoid, kind of looks a little weird, my Y looks a little weird, my body. However, I can clearly see that this is my humerus right here. Does everyone see the humerus? Good. The humeral head is sitting inferior to this. What is this, Sharon? What is this called?
The coracoid process.
Coracoid. So if the humeral head is sitting anterior, because we know that the coracoid lies anterior and on the body anatomically. So if the head makes sense under the coracoid, it's an anterior dislocation. Here, it's kind of fuzzy. Sorry, I was trying to enlarge it. But here we have the Y. Here's the acromion. Here's the coracoid. We don't see the head right at the base of our Y. Here is our body superimposed. But look what we see. We see the humeral head sitting inferior to the acromion. Okay? So just like the Bankart lesion and the Hill-Sachs defect, when you have repetitive, because the glenoid cavity is not that deep. It's not that deep. So it is much easier to have a humeral dislocation than a femoral dislocation. So when you have elastic ligaments and tendons or repetitive injury, it's easy for that humerus to fall out of its socket. Okay? So anterior displacement, and here is posterior displacement. Okay, just adding that. I'm sure that I've told Mr. Donahue not to spend too much time on pathology because we're picking it up, right? And so when we're able to see, if you see a deformity in someone's shoulder, a shoulder is sitting lower than the other, that's your good indication right there that they have a dislocation. And a lot of time, what is the universal? What is the universal grab? When someone has a hurting arm, they're putting it very close to their body. They're not letting it go. They've actually stabilized it for themselves. And so please don't move them. Please don't yank on an arm. Okay? Make sure that you are gentle because this is what you could find. Okay? Questions? So now we're into chapter 6, pathology. So chapter 6 is the lower leg. I've eliminated a lot of your list. However, I want to make sure that we have an ability to go over these because these are more common, okay? So when we're looking at bone cyst versus joint effusion, Wani, what does effusion mean?
Joint effusion
Yeah, what does effusion mean?
occurs to accumulate fluid in the joint cavity.
Okay, so it's accumulation of fluid in the joint cavity, right?
Yes.
Good. And we can definitely see that there is some type of fluid when we compare one knee to another. So we know that this is the site of injury or site of pathology, right? So we'll go back and we'll take a look. And this is where that radiolucent and minus density and plus density start to come into effect, right? When we get into chapter 7, which will be on Wednesday for PRE, we're going to start taking into consideration body habitus. What extra tissue, extra fluid does to our primary technical factors. So, starting off to the left, this kind of looks like a tumor, doesn't it? When you look at this, you're thinking, oh man, that's different. That's a tumor. But the one thing about this bone cyst, and it's benign, it's a benign bone cyst, you start to see the sharp edges. Now remember, tumors start to erode the lining. Remember that when we start talking about tumors and you go back and you start looking at tumors starts to erode the lining of the cortical outline. So this is a cyst. It's pretty sharp. It's pretty solid. Cysts are usually round, not abnormally shaped. Okay, so how does one get a cyst? What does it say in your book? Let me see. Jonan, that's yours. What does it say in your book for bone cyst? How does one get a cyst? Chapter 6.
Page 2.
Thank you, Betty. You got it? If not, I can jump to...
Yeah, I mean, I'm looking at it. I just didn't see it. I didn't see it.
Bone cyst?
Yeah, no, I see bone cyst. I just didn't see a clause on it here. I mean, just they're benign neoplastic bone lesions.
When do they occur?
They occur in children in the joint. So I guess when kids fall down, bang their knees.
They do, and they do. And so what happens, remember we spent a lot of time talking about osteoblasts and osteoclasts. If there is a diversion on the normal repair or the building, tearing down a bone and the building of bone, there's going to be, whether it's trauma related, infection related, so on and so forth. This is a disturbance. So it can be treated. It could probably, depending how fluid filled it is, it could be drained, and it can be treated with either some type of calcium or so on and so forth to rebuild that bone. Okay, but you usually do see it in children around the epiphyseal areas. Joint effusions, it's more difficult. These are obvious. You're saying, oh, that could be some trauma. It could be some inflammation, especially how red it's going to get, hot. Then we know it's some type of pathology. So when we see fluid, excess fluid on a radiograph, we can see that this is a PD. We can see the epiphyseal plates. We still see a pediatric patient, but we're starting to see a discoloration. It kind of looks like muscle, and you're thinking, man, this is difficult to see. But you'll start to see more wider, different types of discoloration where they shouldn't be. We shouldn't have these large spaces. We can see a large space in between the patella and the femur, which we normally don't see. And that is that fluid, that excess fluid that is caught inside of the joint, pushing outward. Okay, so sometimes it'll give you, depending on the fluid and where it's at, it'll give you a radiodense, a discoloration radiodense. What is a fat pad, Sharon? What's a fat pad? And what do they do? Probably learned that up in the upper extremities, a fat pad. You were learning about the wrist and the elbow.
For the cushion?
They are cushions, and sometimes they become radiolucent or very radio evident when there is an indication of fracture and swelling. They kind of get pushed out of the depressions of the bone. They get pushed out of the depressions of the bone, and they start to make an appearance indicating that there is excessive swelling, or there is a fracture, an underlying fracture that's causing that excess swelling. And so we can start to see changes. But this is fluid. This is excess fluid right there, giving you a different color altogether. It almost looks as similar, and it's highlighting actually the tendon right here. So it takes a little bit of time, but this is very fibrous tissue. This is your patellofemoral tendon right there. So it's very fibrous. It's going to give us a discoloration, but not here. This is a little bit abnormal. And if we have a knee that comes up, we'll take a look at, compare and contrast that. Any questions about a bone cyst or joint effusion? Right. Gout is probably, I don't know, you may have a family member, or yourself may have gout. And gout is an it's excessive acid buildup. And you mostly find it more commonly right here at the first MTP, And so what it adds, it's extremely painful, extremely painful. It is an acidic buildup based off of diet. So your diet can actually trigger gout. And what you start to see is there is an erosion of this MTP joint. There is an erosion. The acid buildup there is causing the bone, the joint to erode. So what does it look like on a radiograph? Here we see a sesamoid bone, we see a sesamoid bone, and here is the outer area or the medial surface of the MTP, and we can start to see that there is significant amount of change. It is losing its nice cortical outline. Get it? So cortical compact bone on the outside, you can see the medulla or the medullary cavities, and we're starting to see an opening there, okay, of an infection. So not only treatment, but also diet control will help that person. Anybody know anybody with gout? It's extremely, extremely painful. All right. Well, today I'm going to allow you to have the ride. So let's mark ligaments. And this one is specific because it is right here by the cuneiforms. Right here by the cuneiforms. Right here between the middle, medial, and the lateral cuneiforms, or the first, second, and third. This is where the Les Franck ligament is. And it's basically a stress on the ligament that allows for pain. Can't really see it, but what happens when you have a ligament tear or a tendon tear? What do you think is going to happen, Marisela?
I'm sorry, what was the question?
So if you have a tear in a ligament or a tendon, what do you think is likely going to be evident on a radiograph? Are we going to be able to see the tears?
No, but you'll be able to see
dislocation. Good job. Dislocation. We're not able to see tears of the tendons or the ligaments. Why? Because they're radiolucent. It's cartilage. We're not able to visualize cartilage. Okay. However, we are able to see the placing of the bones and how they are positioned in reference to one another. Osgood-Schlatters disease, that's basically where you start to have a pulling. So there is a tibial tuberosity on your tibia, which is your tibia bone, which is your shin bone. There is a nice bumpy, if you follow your hand down to the lower of your patella, you're going to find a nice protrusion area. That is the tuberosity. This is where the tendon or your kneecap is held. It's attached right there. So what happens when small children who are still growing, you got these epiphyseal plate right where that tendon attachment is at. What happens is when the children are just going and going and going and applying a lot of stress in that area, such as youth sports, you know how I've seen it. I used to be a T-ball mom, a T-ball president, the Little League president, whatever it was that I all did for like about 10, 12 years. You see these parents, and I'm one of them. Run faster! Doing things like that, right? Pushing your kids without even knowing or thinking that you could be impacting their bone growth. And so Osgood-Schlatters disease happens when the tendon pulls on the growth plate, and then sometimes you can actually have it ripped, which will need some surgical intervention. But for the most times, you'll see that a person will have a relaxation of this tendon as they continue to grow, and they will always have pain. Okay? So whenever you're putting your kids in those little league sports, just remind yourself Osgood-Schlatters disease, or make sure that they do some proper training, and never push them more than what they can. But when you get in the heat of the moment, I know, I've been there. So let's take a look at it. Ooh, this is a little low. I don't know if you can actually see it. So it's right here. Oh, remember that normal knee that we were talking about, joint effusion? Look at that little space compared to what we saw earlier, right? Big difference. You know what I'm talking about? Look at the space here, and then joint effusion, and look at that space there, right? Pretty wide, isn't it? Moving the patella too far, and the patella's purpose is to protect the knee joint. But right here is the tibial tuberosity. So what we've done was enlarged it, and this is where you start to see that broken or protruding or pulled tibial tuberosity. And so very, very important because that's what's holding our kneecap in place. Questions? All right. So rickets or osteomalacia. Rickets, it's often called, or osteomalacia. And you hear this. How many of you are history buffs? A little bit, Luke. Now, remember, Luke, when we were having pirates at sail and they were going on these long, long trips from one continent to another? This was probably one of the more infamous types of diseases because what it is, or what causes rickets, is lack of vitamin D. So people who didn't have oranges or anything that was a vitamin D supplement, any types of fruits or minerals or nutrition that could keep, what would happen is the bone becomes so depleted of vitamin D, not by an inherited disease, but because lack of nutrition. So what it does is causes or promotes a fracturing of the bone or a deformity of the bone. Why a deformity? Because you still have to walk around, you still have to work, you still have to do things, and so the bone becomes very soft. Okay, and then you can start to see a deformity. So having a person, especially, and I've heard this, when you would have those people that were a long time at sea and they didn't have the right nutrition or enough supply of food, then they would start to develop these types of abnormalities or deformities of the bone. So osteomalacia or rickets, it's basically a softening of the bone that allows for fractures and deformity. Deformities because of the weight that you have to put on to the body. Okay? Questions? All right. Well, just remember that I eased you into this day. Okay? Because now we're moving on into chapter 7. Ladies and gentlemen, any questions of chapter 5 and chapter 6 before I move on into chapter 7? No? Okay. Ankylosing spondylitis is probably one of the bigger ones, and you'll see that. I think this is huge. We see this in the spine. We'll also see ankylosing spondylitis in other areas. But most commonly, it's referred to as bamboo spine. So when you think of a bamboo tree, you think of layers sitting on top of each other. So what is happening here, the ligaments or the longitudinal ligaments of the spine, that kind of keeps our vertebrae from setting out of each other, right? We don't want our vertebrae to come dislodge. So that starts to calcify. And when it starts to calcify means become bone, become hardened. So the ligaments are now becoming hardened. What do you think that's going to happen, Ruth? What do you think is going to happen to the range of motion of the spine?
It's going to prevent the range of motion.
It's going to prevent bending forward or backwards or flexion and extension. It's going to prevent side bending. It's basically going to be very rigid. Okay? So ankylosing spondylitis is basically what is also AKA known as bamboo spine. And this is the calcification of the ligaments. Questions? Developmental dysplasia of the hip, or DDH. We talked about DJD. What was DJD again, Shibu? What was DJD? Okay, Pamela, help him out. DJD?
It was DDH. What was the question?
DJD. What does DJD stand for? Naomi, help him out.
Trying to remember as well. Let's see.
Degenerative joint disease.
Degenerative
joint disease. And it's AKA for what? I would go back over that before your test on Wednesday.
Osteoarthritis.
Thank you very much. Osteoarthritis. Well, here we have DDH, developmental dysplasia of the hip. Dysplasia is a type of dislocation. Dysplasia, dislocation. So when we're looking at a normal hip, we're thinking of the acetabulum, often called the socket, kind of like the glenoid cavity of the humerus. we have the head of the femur. It is deeper. The acetabulum is deeper than the glenoid cavity. So you have a lot of less displacement. You have a lot of less displacement of the, hold on one second, they're calling me from the clinics. One second. Okay, sorry guys. And so we have what happens is, and you'll find this more in children where you start to have the epithelial, and this is where they'll go back. And I don't know if many of you who have children, they go back and they look at the gluteal folds. So when a pediatrician is doing a normal or a physical on a child, they'll lay the child on their stomach and see the gluteal folds. Usually the gluteal folds will be at the same level. When they don't see that they're at the same level, they'll go back, and it's because it's in the name, it says developmental dysplasia. So we can see a child here in this example of a 1 year versus a 3 year. And so small indications in the gluteal folds, again, the inferior part of the gluteus maximus, they're not at the same level. And this is a good indication of that. So it's not developing, the acetabulum is not developing, and there's not an articulating, there's a complete dislocation of that joint. And a lot of times the children don't give an indication. They might just start limping and you really don't even know or pay attention to because they've gotten used to it. Not necessarily painful. They won't necessarily always demonstrate pain unless they fall or something. But usually pediatricians are on the lookout for those gluteal folds. Okay? So that's developmental dysplasia. Questions?
So basically, you're just saying the femoral head doesn't sit deep enough in the socket, so that's why it's constantly dislocated.
Right. So even here, this is all connected by cartilage. So all of it is still connected. It's not like it's a leg that's just being dragged around. All of this is held by cartilage until you can start to have some type of fusion and articulation of the two bones. So this is still very functional, but and the child may not indicate it, but it is not. If it continues to persist, they will have to do some type of intervention and pull it back into its socket, especially when it's starting to fuse more. Maybe a cast, or putting a child in some type of cast to put that to keep it at the same level.
Oh, so since it's not in the socket, it'll start fusing somewhere else.
Correct. Well, not even fusing, it'll just stay. So as this continues to fuse and age, and you're talking you're talking a decade worth of fusing. So it's not going to go that prolonged. And if you did, you would see an obvious difference in leg height, one versus the other. So intervention. If there was no intervention, then yes, you would have probably limited range of motion here as the child would continue to progress, and you would see a difference in leg length. And you know what I mean?
Yeah. Okay. I got you. Thanks.
Mm-hmm.
Will that be a reason why some people have like a shorter limb?
Yeah, that could be sure, or other areas, but yeah, that could be a reason. So Leg-Calves Perthes disease or leg-calf disease is a flattening of the femoral. I go again. Femoral head. Here is a flattening of the femoral head, and it is just a flattening of the femoral head. So it starts to limit that range of motion, that ball and socket action for the hip. So very, very limited range of motion, but you can see that it is a flattening of the femoral head as opposed to what the normal one is. Okay? Questions? All right. Pelvic ring fractures and proximal hip fractures. We've talked about fractures, but these are specific. The ring of the pelvis, as you guys get into pelvic girdle, probably starting next month. It has to be next month. So this is the ring, or the pelvic ring. And so any fractures along that rim or pelvic ring is going to be considered a pelvic ring fracture. Obviously, those are extremely important to take care of because what is the pelvic girdle doing? It is holding up our intestines. It is where our bladder sits. It is where there are attachments of many, many muscles. It's almost like a bowl in a sense. So if you start to lose the structural stability of that, obviously, one, very painful, and that it can affect or dislocate or dislodge other organs for systematic function. The proximal femur, you can have many different types of fractures in different parts. However, when you get into lower extremities, the surgical neck of the femur, the surgical neck of the femur, the surgical neck of the femur is probably the more common areas of fracture for the hip. The slipped capital femora epiphysis is basically right here where you have that anatomic type neck of the femur. So the slip disc, as this is starting to fuse together like we saw in this child, see this right here? There's an epiphysis right there. That's an epiphyseal plate. So if it doesn't fuse together in the same area, what you can have is called a slipped. It starts to slip off to the side. And so this is very unstable, obviously, where you have total fusion of both whole parts. And here you would only have fusion of half of both parts. Make sense? Half of the femoral head with the neck as opposed to all of it. Okay? So that's at the epiphysis. So it's in the name, slipped capital femora epiphysis. And so this is where it starts to just dislocate itself. Not where the femoral head is out of the acetabulum, but where the epiphyseal plate starts to shift. Okay? You with me, Jesslyn? Perfect. Post-fracture reduction. So this is where we start to have fractures that are now being repaired. Okay? And I wanted to bring this in because many of you are taking x-rays of patients with prosthesis. What is a prosthesis, Jesslyn? Jesslyn, we're good there, okay? I know, a distraction. So let me go ahead and give you prosthesis. Prostheses are metal that we implement inside of the patient to repair whatever it is what's happening with the bone. So here, we're going to have plates. We call these sometimes brackets, and when you've gone to OR, you're going to see that a lot of this in OR, this is what they're using. It's a plain old garage. They'll have screwdrivers, they'll have hammers and mallets and screws and so on and so forth. So these are considered plates. These are considered pens. Our screws are considered pens, holding the neck, the upper hip break right here. And then sometimes you're going to have intermedullary rods. So this is basically rods that are placed on the inside. You'll see this more for our comminuted fractures, right? Here we'll have some fractures, but for our comminuted fractures, that's what we'll usually see, our intramedullary plates. So this person right here has had a hip replacement. They have a hip replacement. Obviously, we can see that the loss of cortical outline, probably something pathological, disease. Okay, so we have a new femoral head. We have a new ring around the acetabulum for structural stability. So this is metal. Hold on one second. Okay, so what you're also going to see are the pens. This is a bracket or a plate. They also have some rings, as you can see. It looks a bit splintered, doesn't it? Doesn't it look splintered right there? We're trying to hold all of these pieces together and allow nature to do what it does, okay? So this looks more like an elbow. This is more of a, well, maybe not. No, that almost looks like a olecranon process, but it's probably the same patient. Yeah, it looks like it's the same patient. Splinter, yeah. So we see the splinter, we see some rings, radial plus density, right? So a lot of this is going to absorb our x-rays going through, which is okay. When you're doing a prosthesis, someone has had surgery, you see a scar, you want to make sure that you've asked them the question, what did you have done? Because you are required to include the entire prosthesis of your objective. Meaning, if they've had an ankle surgery, you want to probably center higher where the scar stops so that you can get the entire prosthesis. It is important. These are halos. How many of you have seen a halo? Okay, so this is a traction device where they basically pull on the device to make sure that the ends of the bones align and it's able to repair itself. The osteoclast and osteoblast are going to work. So this is a halo. This is an external device. However, they're able to pull on the bone from the inside because there are pins that are attached to the bone on the inside. I don't know if you can see that. Okay, they're inside of the bone to allow to do some spacing and some pins right here. We're able to see that. So when you are performing exams like this, let's say you go in and you're doing a tip fib, you need to open up your collimation to include all of the prosthesis. Got it? Yes, Miss Lara. That's wonderful. Sometimes we also, instead of the halos, we'll have these external bars. That's the same concept. They'll pull on it, pull on the traction, just so that they're able to align the bone ends together. So here you can see it on a leg, and here you can see it on an arm. Sometimes the leg is wrapped. Sometimes, depending on how long they've had it in, it's not. Okay? So it's just something that is going to be a part of them until it is complete, depending on what the pathology is on the inside. Okay? Any questions? Well, we are done. We are done. I have an emergency at a clinic, so I may not be coming back at 10:45. I'm going to see if Mr. Donahue can switch with me and see, and I'll pick you guys back up in the afternoon, okay? All right, well, y'all have a good one. No questions, right? Au revoir.
I have a question.
Oh.
For the tests,
I think she'll be back.
I'm going to ask about what's on the test. Are there x-rays?
Everything that she went through.
Everything that's on the PowerPoint's on the test, all the information. I'm not sure if there's going to be actual x-rays, but she did say to know what they look like.
Usually, what she does with this one, there should be a couple images, but not a lot.
And also the Evolve.
Yeah.
Even though the quizzes are due on Friday, everything from the Evolve quizzes is on the test.
So 1, 2, and 3 are due this Friday. So that's got to be on the test too.
Everything. You know.